Good afternoon, everyone, and you're very welcome on this sunny afternoon to the next in the series of webinars from the Royal College of Surgeons, organised and run by the network of regional surgical advisors for the college. I'm really pleased to introduce one of my colleagues, a colorectal surgeon from Harrogate, Claire McNaught, who is also the Honorary Secretary of the college. So I think we'll get on. Claire, I'd be really grateful if you could take us through your talk on the principles of stoma formation and their management. Thank you.
That's great. Thanks very much, Steve. And again, welcome to you all, particularly for signing in this wonderful day. I'm not sure I was as dedicated when I was at your stage. So today I've been asked to talk to you a little bit about the principles of stoma formation and management. And over the next 20 minutes or so, what I want to talk to you a little about is about the myths that people, the population have about stomas. I think we need to dispel them completely. And then we talk to you about how we actually define them, what the indications are for their formation, how we actually go about doing that, and then a little bit about the management of some common complications. And at the end, very happy to take some questions. So first, a little bit of a quiz for you, if that's okay. So how many stomas do you think are formed in the UK every year? Is it 1,000, 10,000, 25,000 or 50,000? What do you think? Have a guess, because it's just, it gives you an idea about what you think and how common this condition is. Let's see what you come up with. And the poll is, so yeah, well actually you're all in the kind of right line there. Actually about 9 to 10,000 stomas are formed every year. But actually that means that in the UK at any one time, there are about 120,000 patients living with a stoma. So it's really quite a considerable problem in our population. Now, a few years ago, Colostomy UK, which is a charity that supports patients with stomas, did a survey of the general population, and they came out with what we call the common myths. And I really think it's important that we can dispel those myths. And one of the first ones was that only old people have stomas. Well, as you can see from this young woman who was in an independent paper recently, that's not the case at all. And in fact, even many babies have stomas, so it affects all age ranges. A lot of people thought that stomas are always permanent, but actually in our society, about 35% are formed as a temporary stoma and are actually subsequently reversed, which is good news. One big thing that people worry about is that everybody can tell you've got a stoma. But if I would say to you, if you were standing at King's Cross Station before lockdown, I hasten to add, when there's maybe 1,000 patients, it's likely in that population that 2 or 3 people will actually have a stoma. And I'm sure you've never actually thought about it. So most people can't tell that another person in the public has a stoma. And the other thing people worry about is the smell. But what I would say, you always have to tell your patients is that the appliances that we have now are really good. They're completely odour proof. And of course, when they change the bag, it smells. But when you go to the toilet, it smells too. So that's absolutely no different from anybody else. Another sort of commonly held myth is that people with stomas can't eat and drink normally. And actually, that's not true. There are certainly certain dietary things that they might want to follow that makes their stoma management a little bit easier, but they can really have a normal life. People often worry about maybe they can have an intimate relationship or can they get pregnant with a stoma. The answer to that is absolutely yes, although, as I'll touch on later, having a stoma does reduce your psychosexual function, but people can get pregnant. But you have to remember that some of the disease processes that you have a stoma for example, inflammatory bowel disease, might reduce the fertility in a young woman. And the other thing about having stomas is that people say you can't be active. Well, that's a nonsense. Look at the girl in that picture. People can swim. Remember, the appliances are waterproof. They can be as active as they like. Again, there are some tricks that help them to manage that. But you can have a very normal life with a stoma. So that's all the myths. Now, when I was a medical student, I always remember going onto the wards and hearing the consultants talking about jejunostomies, ileostomies, colostomies, and I'm thinking, I have absolutely no idea what they're talking about. So I'm going to try and simplify that for you. What an ostomy is, it's essentially just an artificial opening in an organ of the body, and then we bring it onto the skin. And so whatever that is, everything that's just an ostomy. And whatever bit of the bowel you pull out, you put the name in front of ostomy and you've got it. So if you pull out a bit of the ileum, it's called an ileostomy. If you pull out the jejunum, it's a jejunostomy. Or if you pull out the sigmoid colon, it's a sigmoid colostomy. So it really is quite straightforward. There are only two situations that can be a little bit more tricky. So if you have a urostomy, where it's something to divert the urine into, you actually do use part of the terminal ileum for that, but you've taken it out of the gut circulation and you've plumbed the ureters into the bottom. And we don't call that an ileostomy, we call it a urostomy because it's draining urine. And the only other thing you might want to know about in terms of terminology is something called a mucus fistula. And if you look at the picture at the top of the picture of that young baby, they seem to have two stomas on their abdominal wall. And the top one that you see is actually a sigmoid colostomy, but the bottom one is the other end of the bowel, and that's been brought up to the skin to facilitate putting it back in due course. And because that's not producing anything, it's not in circuit with the gut, we call that a mucus fistula. So if you see two stomas, it's likely that one of them is going to be called a mucus fistula. So why do we form an ileostomy or a colostomy? Obviously, we do it often in an emergency situation where we have to divert the fecal stream. And basically that's really any condition that you go into the abdomen and you have to take a bit of the small bowel or the proximal colon out, and you don't feel it's safe to join the patient back together again. We call that anastomosis. So there's a whole range of conditions. Probably the most common is inflammatory bowel disease, Crohn's disease, or like the X-ray you see there, something called a toxic megacolon, where the colon is rapidly dying off, and sometimes we have to remove the whole colon in an emergency, and you have to do an ileostomy in that situation. In any cause of peritonitis, sometimes you might choose not to join the patient up, and even in patients who've maybe got chronic obstruction, they might be very malnourished and cahexic, and in that situation, again, it might not be safe to do a join, so you might give them a temporary ileostomy. I think in emergency surgery, one of the commonest reasons for an ileostomy is for mesenteric ischemia for whatever cause, and very rarely for radiation injury or hemorrhage, we might do that again. But I mean, remember I told you at the beginning, it's not just adults, also children have to have ileostomies on occasion, and probably in young children and babies, it's necrotizing enterocolitis is the most common indication. We also form ileostomies in a planned fashion, or what we call an elective situation. And probably the most common cause is when we do rectal cancer surgery. You can see the picture here of an MRI of rectal cancer. And when we remove that, we have to do an anastomosis or join very low down towards the anal canal. And we know that in about 10 to 15% of patients, that anastomosis won't heal. And if the patient's not very fit, then we might might actually do an ileostomy to protect that joint and then put the ileostomy back later on. So that's probably the commonest reason why we do an elective ileostomy. We sometimes have to do that when we have to remove the whole colon and anal canal, and we often sometimes do this also in inflammatory bowel disease where patients have had pouch surgery. So that's the most common elective indications for ileostomies. In terms of colostomies, it's just a slightly different spectrum of disease, and the most common is probably for colonic obstruction, possibly due to a diverticular stricture, or even maybe due to a cancer, although now we often try and put a stent or an internal tube inside to relieve that obstruction instead. Any cause of colonic perforation, whether that be trauma, acute diverticulitis, a cancer, or something called a stercal perforation. You often see that condition in very elderly or frail patients, or sometimes in patients who've got handicapped or mental disorders. They get very, very constipated, and the very hard stool will actually erode through the bowel. And in that situation, we certainly do a colostomy. And the image you see on your screen now is an operation where operation to do to form a colostomy, where we remove the sigmoid colon, we leave the rectal stump behind, and then we form the descending colon forms the colostomy. So that's a Hartmann's operation. We also have elective or planned colostomies, and we often do that in patients who maybe have a very, very low rectal cancer that we actually can't do a join below it, and we call that operation an APER. We sometimes use colostomies in unfit patients who have chronic cancers, And we also use it in benign conditions, such as patients who have got intractable incontinence and they've tried everything else and nothing else has worked, people with severe peritoneal sepsis, and sometimes in patients who have fistula disease, either rectovaginal fistula or colovesical fistula, although quite often we can do a primary anastomosis in these conditions too. So that's the common indications for why we would do a stoma. But how do we actually go about doing it? Well, I think one of the key things is actually, before you actually do a stoma in a patient, is to actually mark the patient and actually get them some counselling. Now, if you've in an elective situation, you've got time, it's really important that your patients meet the stoma therapist so they understand what's going to happen. It's often really helpful to meet another patient with a stoma so that they can actually learn to understand what it's like living with a stoma. But obviously, most of these are an emergency situation. But if you can just take 10 minutes to actually try and mark the patient beforehand, because this is really key to their performance in the future. So you want to try and mark that, get the stoma under the belt line if you can. And in an obese patient, that's not possible. Sometimes it has to be above. But you want to try and avoid any skin creases. So you want to try and get the patient sitting up and moving around. You want to make sure that the stoma site is away from the bony prominences, so that actually when you do have an appliance, that it fits nicely. So this is a very key part in when you form a stoma. And how do we actually do it? Well, if you're doing an emergency operation, it's often an open technique. But sometimes if you're just doing an ileostomy or a colostomy, you can do it laparoscopically or keyhole. But this is basically what we do. And you can see the diagram here that we basically pull the end of the ileum and it passes through the abdominal wall and through the skin and through a hole that you've made. And then you can actually see from that diagram, for an ileostomy, we almost fold it back on itself. And the reason we do that is we want to make it very prominent above the skin, because obviously your small bowel content isn't a neutral pH, so it can really damage the skin. So if you can get it away from the skin so you can get a nice fit with an appliance, it reduces their skin complications. So we call this here an end ileostomy. As you can see, there's only one lumen there. And that contrasts to something called a loop ileostomy. And we use this technique, it's still just pulling out the ileum, but we pull the whole loop of the bowel out, we fold it over itself. But as you can see here, there's two lumens. One lumen is where all the GI content will come out, and the other lumen is where the next end goes. And the reason we do that is that if we're going to reverse the ileostomy in quite a quick time period, we don't have to go back into the abdomen. We can just go round the loop ileostomy, and we can actually join it all together outside the body and put it all back in, and that minimises the impact of that second surgery to the patient. So that's called a loop ileostomy, and you'll see the two lumens there. It's kind of exactly the same for a colostomy, although we tend to form them a little bit more flushly because it's a neutiral pH. But when you form a loop colostomy, because the colon's a lot heavier than the small bowel, you might see patients with a little plastic bridge under the loop, and you'll still see the two lumens there, and that's called a colostomy bridge, and that only stays in for a few days until the tension is really taken off the stoma. So colostomies and ileostomies can either be end or they can be loop. So here's the next question for you all today. Given that I've told you that, what type of stoma do you think you see in front of you? Is it a loop colostomy, a loop ileostomy, an end ileostomy, an end colostomy, or a urostomy? I'll give you a few seconds just to have a guess at that. Okay, shall we see what the results of the poll is? Excellent. Well, at least 85% of you are listening, which is wonderful. So very well done. If anybody had actually said a urostomy, it could have been, if there was, urostomies often look like ileostomies, but the thing that would give that away is that there'd be urine in the bag. So well done, all of you. So I think it's sometimes you walk into a ward and you see a patient with a stoma and you're thinking, well, the consultant might ask me what type of stoma is that? And when you look at this stoma here, well, is that an ileostomy? It's not very well formed. Sometimes in an obese patient, it's quite hard to get a nice loop, a nice spout on it, or is it a colostomy? So things that might give you a clue to that is, first is the sites. Ileostomies are usually in the right iliac fossa. Colostomies are more generally in the left, but that's not invariable. The size, ileostomies, the small bowel slightly smaller, but again, that can be misleading at times. If you see a very nice protrusion, it's usually an ileostomy, or if it's flush with the skin, generally a colostomy. But the thing that often gives it away is the content in the bag. So if it's very well-formed hard stool, it's more likely to be a colostomy than an ileostomy. And obviously, if it's urine in the bag, then it's a urostomy. So I'm going to talk to you briefly now about some of the complications of stoma formation. Unfortunately, these operations, they do have quite a high morbidity associated with them. For various reasons, because often they're formed in an emergency procedure when the patients aren't very well. So sometimes you might get infection around the stoma. Stomal ischemia, well, that's when the stoma doesn't survive, the stoma becomes necrotic. And as you can imagine, you're taking often the ileum or the colon through the abdominal wall, and you're relying on the blood supply that's coming up through that area. And if these people have been on inotropes and they're very vasoconstricted, sometimes they don't survive. And that's a bit of a disaster. You actually have to go back and actually revise that. Sometimes the stomas may retract. In the early post-operative period, sometimes you get obstruction of the stoma, but probably the commonest early complication is high output, and I'm going to come back to that in just a minute. In terms of longer term, well, sometimes over time, the colostomy or ileostomy can stenose. The scar tissue around the skin can actually almost overgrow, and sometimes, again, you have to reform them. Sometimes the stoma can actually start prolapsing out, and so you get an absolutely massive stoma. That's very common, particularly in transverse colostomies, and again, they have to be revised. But perhaps the two commonest long-term complications are the skin problems, very, very common, very distressing for the patient, and parastomal hernias. This textbook said 5 to 15%. I actually think the longer you wait, almost invariably everyone gets a stoma and parastomal hernia eventually. In most patients, these don't require any treatment, just maybe a change in the appliance that they use, but sometimes you do have to go back and repair them. And we talked before about the psychosexual dysfunction, and the other big common complication or a symptom that patients find distressing is if you've got a stoma but you've still got your rectum in situ, you can quite commonly get some rectal discharge from that. That's a very normal side effect, I'm afraid. I'm just going to quickly mention high output stoma, because no matter whether you become a surgeon or whatever speciality you end up in, you invariably meet someone with a high output stoma, and you really have to be careful, because these people can go into renal failure very quickly. And essentially what happens is their stoma output's too high, they get water and sodium, magnesium depleted, and it tends to occur when people have got very high stoma outputs, but it can be quite less. It can happen in lower stoma outputs if the patient's input's not very good. So the first thing to do is to exclude other causes, make sure they haven't got an infection, make sure they haven't got a partial obstruction. They need to be rehydrated. You want to restrict a little bit about how much water they're drinking, because if you can imagine, because it's hypotonic, that pulls more sodium into the GI tract. So we say about 1 litre a day. They're much better to drink either oral rehydration solutions, because that's isotonic and they have less electrolyte loss. So we say double strength Dioralyte all mixed up is the best thing to drink. We also like to slow down our gut transit, so we use loperamide to do that. And we also reduce our gastric acid secretion with omeprazole. And this is a key slide for you, because I say you will all come in across that. And sometimes with these very, very simple steps, with a few days, you can get a patient go from somebody who's very sick to being very well again. So that's how we manage that. So we're almost done. I just wanted to mention quickly about what it's like living with a stoma. I think that over the years, there's been many, many more appliances made, and most patients will have a single appliance where they have one piece with a adhesive sticker on the back that they stick onto the abdominal wall, but some have a two-piece where they have what they call the phalange and a bag that they put onto that. And we tend to use that in patients who maybe have a skin recess, because obviously when you form a stoma, the patient might lose weight, or they might put on weight, and so the abdominal wall changes. And there's lots of different appliances that you can use in those situations. And what usually happens is that the patient will work with a stoma therapist, and they'll find the best appliance that works for them. And it can be trial and error, and it can be difficult for them, but generally there's a stoma appliance out there that will suit every abdominal wall. final slide really, what about a quality of life with a stoma? Well, there's no doubt that if you have a stoma formed, particularly as an emergency, it has a negative effect on your quality of life. But in saying that, most patients with stomas actually have very high scores. So the people can have a very normal life, can go on with their life, but they'll take a bit of a hit when they have it. And of course, people will worry about normal things. They worry about their diet, about gas formation, leakage, and particularly the skin things. They worry about their body image. You know, we can all understand that. And unfortunately, sexual dysfunction can be quite common. But I think what my key message is to you is that when you have good support from a stoma therapist and from your family and perhaps some support groups, that actually with time your quality of life improves dramatically. And so just to say that most people who have a stoma actually have a very full and very active life. So just to finish off, to say that stomas are actually very common in the UK. The indications for their formation are diverse, but basically it's any condition where you have to have fecal or urinary diversion for a time. Pre-operative sighting and counselling is essential. If you can do it early, that's great. We can do it by keyhole, we can do it by open surgical methods, and end or loop stomas are the most common. The complication of high output stoma is probably one of the most common emergency presentations of people with stomas, and parastomal herniation is really the other one. Yes, stomas cause a reduced quality of life, but you can have a very good life. And just remember, a lot of these patients had stomas for life-threatening conditions, so often a stoma has saved their life. Okay, thank you very much. I'm happy to take questions now. Thank you.
Thank you, Claire. That was really interesting. And it's actually quite a complex subject whenever you think about all the potential indications for having a stoma. And it's obviously it can be a life-changing surgery for our patients. But I think, you know, my own experience as a colorectal surgeon is that really with support that patients really adapt very quickly to having a stoma. As you say, that actually sometimes the quality of life is better than very, very poor bowel function. So I've got been lots of questions posted, and I'm just going to choose actually probably just two of the most interesting ones. So one's very topical and one's maybe slightly unusual. So have you sometimes women in pregnancy become very unwell, and I think I've operated on one or two in pregnancy and formed a stoma. But this question actually relates to patients who have a stoma and then become pregnant. Are you aware of any complications that those obviously young women can then suffer in terms of stoma complications or problems when they become pregnant? Is that something you've been involved in?
No, I haven't actually seen that many. I always think it's incredible how adaptive the body is to pregnancy changes, and even nutritional changes. I suppose when I see patients, say initially with very sick Crohn's patients who are very emaciated and they have very, very thin abdominal walls, and then you do a stoma and then you see them a year later and they've put on 3 stone, and yet their stoma's absolutely fine. You know, there's no problems with their stomas at all. So it's like everything, the body works things out, and through the pregnancy changes, it adapts. Quite often, they may have to change the appliances that they're using. Maybe, as I say, if they get different lumps and bumps and things start to get pushed to the side, they have to maybe change their appliance. They may have to use a little belt with their appliance just to hold it in place if it's more difficult to position. But I haven't seen any major surgical complications in people with pregnancy, to be honest.
No, nor have I. I mean, as you say, having a stoma isn't a barrier to young women having being sexually active and having children and having normal deliveries. I suppose sometimes I've been involved when the obstetricians are concerned that maybe a woman's had complex pelvic surgery, you know, like an ileoanal pouch, and they sometimes want us to get involved if the patient's still got a stoma. But I've never seen pregnancy causing problems with the stoma itself. Nope. So that's really interesting. I've got another very topical question, Claire, I'm really interested in your thoughts about. I mean, particularly given your role in the college, and I think the college has quite a lot to do with some of the guidelines. So obviously there's a COVID pandemic, sweeping the world, and we've seen early on data from China and from Italy that people who were getting complications in the post-operative period after major surgery, particularly for cancer, and who developed COVID in the post-operative period were at high risk of death. And so there were guidelines from lots of different surgical societies across the world saying we should be much more conservative then maybe we wouldn't be doing a primary anastomosis. Maybe we should be forming more stomas and not joining the bowel. And I think this is maybe, we probably don't know the answer to this, but I wonder what your thoughts are. So one of the attendees has said, has the COVID pandemic increased the number of stomas formed?
Well, I think I don't think we definitely know that for sure yet, although we're, I think almost all surgeons are trying to put their data into the COVID surge database, because I think that's really important information that we need to have. I think what is there are early reports coming out that people have to get a post-operative COVID pneumonia after a major colorectal resection have up to a 25% mortality rate. That's almost 10 times the mortality rate that you would expect in a normal elective procedure. So is it making us more cautious? Absolutely. And so I think that I'm seeing my patients now, particularly patients who are maybe in their early 80s, who I would say they had a sigmoid cancer, and I would usually have no qualms at all about just doing a primary anastomosis. In that situation, I would carefully counsel the patient to say, if you get a problem in the post-operative period and you get pneumonia, with having a stoma, it takes another risk out of the equation for you. Because even people in their 80s who get an anastomotic leak are pretty sick, and it's pretty hard to get them through and to survive anyway. But if they get in COVID on top of that, it's almost invariably would be fatal. So I think that I am having more of those discussions, and I'm very influenced by what the patient feel about it. And I think at the end of the day, it is a decision. If the patient was very, very high risk, I would certainly try and persuade them more along the stoma line. But really, at the end of the day, I think that's a decision to be made between the patient and the surgeon, really.
Okay, well, that's a really interesting response. And so the database that you referred to, is that a national database that anybody, an international database that anybody can submit?
Yeah, it is. So COVID Surge is a collaborative research project that's ACP, so the Association of Coloproctology are helping them run this, and it's basically putting all surgery, general surgery into data, including cancer surgery. And they're already getting data out, for the first 4 to 6 weeks. And what we already know, it's only maybe in a couple of hundred patients so far, that if patients do get a COVID infection, if they don't get a respiratory infection, their mortality rate is twice of normal, so it's about 5%. But if they do get a respiratory complication, it's 25%. So, but that's early data, and it's small numbers. So I would suggest that everybody goes online, look up COVID surge, and you can, especially at the moment, medical students are perfectly positioned to collect that data with our help. And obviously you'd get a publication and a collaborative research publication. So I would say, if you've got time, chaps, get involved. It's very important.
Yeah, absolutely. And these big data sets from across the world, obviously, the more people that input data, the more valuable they are.
Absolutely.
Well, Claire, well, thanks very much indeed for your talk this afternoon. That was really interesting. We have had lots of questions posted. I'm afraid there just isn't time to go through all of them, but I think a lot of those questions actually showed a lot of insight into the subject. Thank you very much again, Claire. Thank you, Mike. Thank you to the college. Thank you for all of the regional surgical advisors who are going to contribute to these webinars. The next webinar, as you can see on your screen, is by Mike Silver.